Good morning, good afternoon, good evening, Section 3. Welcome to the Week in Review Knee Pain, both knee OA as well as anterior knee pain. I hope you all are doing well. Man, it's been a busy week. I don't know about you guys, but I feel like there's just been a lot going on. So if you're feeling a little overwhelmed or a little fatigued by the end of this week, I think it's justified. There's been a lot of information to take in, and I have made this, it's not incredibly long because I don't want to add to your already long workload, but I do think it's good that we review. So let's start with the cats. As a rule, I think y'all did a great job. They were solid, and I thought everybody had decent articles that people did a good job of engaging others in and talking about some of the common limitations of the studies as well as some of the benefits. And that's, I think, the whole point of this project is really to get people to critically analyze the literature so that when you go and read your own stuff, you can say, well, I'm gonna follow this article, but I'm not gonna follow this one, or this has some good points, but it has its limitations. So, getting underway, alpha and the functional stabilization on patellofemoral pain. This was an interesting article looking at training just with females, functional training versus standard training, to determine, what functional training, what would that be a better approach with females. It didn't have any carryover for males. The functional training did prove to be better, but whether it could be better for everyone would be called into question. They would need to add males, I guess, as along the way. But I think that this functional stabilization approach could be something that one might think, I might try to incorporate more of this into my rehabilitation with patellofemoral pain. Bravo looked at more manual therapy and hip exercise, comparing manual therapy and exercise, better to exercise alone for hip OA. This has kind of been an ongoing debate, whether you need the manual therapy, is exercise just enough? And they found that those who had hip OA followed with the Altman criteria benefited from this type of program, but that perhaps we need to find further subgroups who may benefit more from manual therapy. I think that really, we're seeing this more and more, that just because you have a particular label may not mean that you are destined to have a particular treatment, and even finding that within that umbrella of diagnosis that we need to be more specific. Charlie, in their discussion about, or their article about supervised physical therapy versus home-based for rehab, this created a little consternation among people. Like, our ACL rehab people just need a couple of exercises and send them on their way and they'll do fine? There are some people out there who will do just fine with that, and there are others who won't, just like there are copers and there are non-copers. And there's a lot of variables that go into that, everything from who they are psychologically to who they are physically and what they want and kind of how they expect to get better. We need to find out who those people are and get them back. So I don't think this article really should scare anyone, but it creates interesting observations and good discussion. And the cat that you guys did was all very well done. For moving on to Delta, rather, while it would be good looking to see this article where PNF versus stretching, strengthening, and then aerobic exercise. This whole article I mentioned to the Delta group, I'm a JOSPT reviewer. I review probably 4 to 6 articles a year. I'd toss this one out. This to me just seemed like it was just impractical. I didn't feel like it was valuable, and hopefully, as you can analyze the stats all you want, but clinically, how relevant is it? Well, you can see not many people look at the benefits of PNF. This study did, but it still struck me as poor with so many visits and a whole lot of stretching. We already know that strengthening it for patellofemoral pain is kind of the key. And an exercise program that I thought, was not based on some really sound research. So as a general rule, I thought this article wasn't great. I did think the cat that you guys did was good, but this article left me wanting to just kind of chuck it. Moving on, literature. The literature that we talked about this week, some of the different articles, the Collins et al. Article, the non-surgical treatment of anterior knee pain, that kind of systematic review. Basically they found that the multimodal approach was a good thing, that regional interdependence is where we need to go with anybody who has anterior knee pain. But but things like foot orthoses didn't seem to really change much in the literature, and that the manual therapy, they kind of came to the conclusion that the literature didn't support manual therapy, but that the literature wasn't very good. So that you should not abandon manual therapy, but you need to keep your eye peeled for better literature that that delves deeper into it. And as a profession, we need to support that kind of literature for these these kind of patients. The Dial article is an article that is a kind of a seminal article that's been used for since it's been out for years to support manual therapy and exercise. Even though at 1 year they were both about the same, that's that kind of whole regression toward the mean. In the early phases, though, wouldn't you want to be at that manual therapy and therapeutic exercise group that they were better off, they felt better, they, we'll talk more about self-efficacy as this thing goes on, but this is kind of a self-efficacy issue. If you can get people feeling better, you can get them moving better, and they ended up having less meds and have better patient satisfaction. The Fitzgerald article on knee OA and exercise perturbation training, whether it's necessary to add that balance or more dynamic stuff, it showed that not much change with the perturbation to warrant its use, but perhaps this doesn't mean we don't use perturbation training. We just continue to monitor this with future literature. Perhaps there is a certain group that will do better than others, and this article didn't really tease it out. Again, it was like under this giant umbrella, so it's hard to really know. But I think these are great articles to keep on hand as you move forward in your profession, to refer back to them or to think back. Well, as you continue to collect articles, when these articles like these come about, how they compare. So the presentations, the Fitzgerald knee OA rehab factors. I think that's one of the great things about EIM is that you not only do you get to hear authors, or you get specific articles by authors, but then you also get to hear some of these same authors give you presentations or lectures. I think that's the power of EIM, and I love that Fitzgerald was able to do this. And she found with these knee OA rehab factors that one size doesn't fit all, taking into account many different things: obesity, instability, fitness, psychosocial factors. All of these things played a huge role in determining that person's outcome. She also talked about unloading braces and lateral wedges. I got to admit, I don't use those very often. They are given out at some of our orthopedic centers quite frequently. I question their efficacy. I know that they cost a lot, and they probably are able to bankroll some of that money at these orthopedic centers. I don't know if they really make a huge difference. But she also emphasizes creating this positive working environment, because that will help the patient progress with a strong sense of self-efficacy. Again, self-efficacy is really important. Do they feel like they are making progress, and are they going to get better? Booster sessions, she talked about there being no evidence, but there being some good discussion on this. And I don't know if I kind of brought this up in one of the threads. Medicare pays for one visit to a physical therapist yearly, whether there's something wrong or not. You can parlay that into more visits if you find functional limitations and levels of disability. But we should, I don't do this, but I think it's perfectly appropriate to encourage people to stop in once a year and just get a checkup. I don't think there's anything wrong with that. There's as much research for dental cleanings and general physical exams don't really show that to be a huge benefit, especially between the ages of like 20 and 50. So why not check up with a physical therapist? I don't think it's a bad idea, and I think that we could probably build some research off of it to support its use, certainly as much as a dental cleaning or a physical exam. Moving on to standout posts, Alpha. Jamie did a nice job of talking about grouping of patients who will respond best to certain treatments. She brings up samples of the Japanese housewives when they talk about the lateral strapping article, and that subgrouping of patients. Maybe there is a particular group of patients. Whether we can nail it down to quite that finite of a group could be called into question, but we need to better understand who benefits from what, so that the patient gets what they need, not more nor less. Sarah goes in Group Bravo and went into great depths regarding self-efficacy and demonstrating the strong correlation with knee OA. She found a separate article that supports that the self-efficacy improves, so does functional progression, and we need to continue to keep people upbeat and focused on attainable goals, and include them in goal making, as well as trying to help them realize their progression through that. In the Charlie group, Danielle does a great job of speaking to the importance of regional interdependence with anterior knee pain, and if SI manipulation should be part of your manual therapy plan. SI manipulation is an interesting concept with patellofemoral pain. The CPR is interesting. I'll attach that as an article for you guys to see because I think it raises some interesting points about the neurophysiological effects of manipulation, as well as maybe there's a group of people out there, again, that wasn't validated, the CPR, but maybe there's a group of people out there that can benefit from that. treatment. Matt C points to the importance of regional independence and hip strengthening, both abductors and external rotators. I haven't brought this up. I thought since he had mentioned it, I wanted to make sure I make a point of it. If you're not strengthening those muscle groups with patellofemoral pain, anterior knee pain patients, I think you're doing your patient a great disservice, both in non-weight bearing and then progressing to weight bearing. That's what a lot of the research shows, and I think that's where we need to be going. Okay, week 5. So week 5, we're going to talk about knee ligamentous and cartilaginous issues. I'm going to send out new groups. The fits won't change, so those people, the fits who are going in Alpha Bravo Charlie Delta will stay there, but you will be switching around in your groups. Your group projects, the subjective information has been posted. I would encourage you to make contact with your groups and then see and get the subjective information and be reading through that. Make contact. I think that's the biggest thing. Grades. I need grades. I got to once I get your information in, I can plug it all in. I'm missing a few people, and I'll be passing out. Hopefully the grades will be wrapped up at the latest by Wednesday. I'm hoping to get them done Monday night. But I can't get them done unless you all get them. And you expect to hear from me a simple couple of sentences on what you're doing well, or maybe perhaps some suggestions on what you can do better to help in this course, as well as some kind of percentage grade that you can see where you're at here at the midterm. And obviously, if you have questions about any of that, please feel free to contact me. Everybody's doing, for the most part, pretty well. I'm not too worried about anyone. And then take a deep breath. Maybe that's just me. Maybe I'm the one who needs to take the deep breath. But like I said, it's been a busy week between the cats and all the presentations and the literature and the postings. And I know that a lot of you have weekend intensives as well. It does get to be a lot, as well as the rest of your life that's going on kind of in the background. So hope all are doing well. Contact me if you're having any issues. Again, if there are problems, please let me know. A couple of people, we've had a couple of issues where people have gotten sick or had to go out of town, and they've kept me in the loop so that I don't wonder, hey, what's going on? I appreciate that, because then that allows me to, understand that they're not going to be there, and not to try to think about, well, what do I have to do to get them on board? So again, hope all are well, and I think week 5 now will calm down a little bit as we move forward.